Good evening, everybody. And I want to welcome all of you to our webinar tonight entitled Let's Get Chemical, Understanding How Basic Chemistry of Materials Affects Day-to-Day Practice. So first, I want to thank my loyal followers. I know many of you have heard me speak on this platform before. I was informed tonight that it is my league-leading 35th webinar on Viva Learning. So that's always fun. And this marks off a very busy week for me, as I have a webinar tomorrow night for the Maryland AGD. And I also have a webinar for Ultradent on lasers on Friday. So it's a crazy busy week. So if you're inclined to be a junkie, then and live in Maryland, you can join me in Maryland or Ultradent on Friday. But tonight, we're going to focus on chemistry and materials, some new things. And I'm going to just kind of pique your mind a little bit to get you thinking, because day to day, you know, we go through our routines and we just don't always have the time to look intrinsically and think. And I'm going to show you some things. It's going to get you thinking a little bit. So everything I talk about is my own photography. For good or for bad, I've taken in my office. I want to thank Vista Apex tonight for sponsoring this program. And we're going to talk a lot about some new innovations from Vista Apex and, again, get you thinking a little bit. I'd like you to friend me. I like friends. So add Vino Dentino on Instagram. Feel free to friend me. You'll see I posted some new technology on there just today if you friend me. But most importantly, I do talk about my second love after dentistry. As my vice, I talk about fine wine. I'm drinking it tonight, a Pinot Noir from outside of Napa Valley, one called Sea Smoke. Some of you may have had it. It's really outstanding, and that's my, I'll be sipping that through the webinar tonight along with a big glass of water. So Vino Dentino on Instagram, feel free to friend me and you're gonna catch some wine tips, but some new technology as well. I'm also a proud board member and a member of Catapult Education. We are a group of key opinion leaders that consult, teach, speak with manufacturers, educate dentists, get to play with things sooner than most people, give our advice. All of these things we do day to day as part of me wearing the other hat. And as a group, Catapult Education works with many dental manufacturers on a consulting basis. This is just a small list. And it's kind of a hand-in-hand relationship. They listen to us, take our advice. We help them out. Tonight, Vista Apex is sponsoring this program. So again, one of the companies we're always working with. Besides all that, I want to let all of you know that I practice full-time in my 2 offices in New York. So I do wear a lot of hats as I practice full-time. And I do, you know, in the past, before COVID, I was traveling a lot. Well, now there's really almost no travel. So just doing a lot of at-home speaking and talking a lot into my computer. But on one of my travels, about a year ago, I was actually in Israel giving a lecture. And on my day off, I went wine tasting outside of Jerusalem. And we were at a winery called Petit Castel, tasting wine. And I started talking to this gentleman. You can see there's 2 wine glasses there. And I want you to turn the sound up on your computer because there's sound in the background at this winery. But we started talking about dentistry and I said, hey, wait a minute, stop. I want to record you. So check this out for a second.
I think, unfortunately, dentistry is one of the most progressive businesses on the planet. They're still doing the same thing that they were doing 30 years ago. So they're taking x-rays, they're drilling with the same drills that make the same amount of noise. Now the actual drills might be more advanced, but as a patient, you're still sitting there and hearing the same drill noise.
What about the instruments?
30 years ago.
The instruments the dentist uses.
Well, most of the time I feel a pick and a cleaning that is still in the same fashion that it was done, in my humble opinion, 30 years ago. So I could be totally wrong, but my industry, which is the money management industry, it is very competitive. Prices are going to zero. You can buy, smart beta funds. You can buy ETFs. People are always asking us to increase our level of service. So I don't know what dentists would say to that, but I'd love to hear their response. I think
So if you heard carefully, he said dentistry is a regressive profession, not progressive, regressive. That's what his perception was as a patient. We're doing things the same way over and over again. Well, tonight, at least initially, I'm going to talk to you about maybe changing some of the things that we're doing, getting to think differently, and by the end of the night, maybe enhance some of the things you're doing as we relate to endo. Let's first talk about, though, restorative dentistry and dental materials. You know, manufacturers, first of all, you have to understand, only bring products to market that have undergone vigorous laboratory testing. There's no way any manufacturer is going to bring something to the market if they don't think it works. Now, they've also usually had many key opinion leaders use the product before it's released. So it's not only a product that's been tested in the lab, it's been tested clinically. It's been FDA approved already. So when we test clinically, we're not experimenting on patients, but it's been used in the laboratory and has been used clinically before it's brought to market. So it's important to know that in general, dental materials are not fragile. They're all meant to work. I mean, the best way I could kind of describe it to you is if you think of the soon to be released, hopefully, COVID vaccine. People have been asking me, am I going to take the vaccine? My answer is, I'll be first in line, because one thing for sure, they're not going to release a vaccine if they don't think it's safe. It's not going to kill anybody. Will it work? Well, that's a different story. I'm assuming it's going to work. But the same thing with materials. You know, materials aren't that fragile. No one's going to release a material that's going to not bond or discolor right away or be too difficult to work with. They have tested that material over and over and over again. But for years, up until I'd say the last 4 or 5, many products, many materials have been similar. So if a company launched a product, another company launched a similar product. And if we just talk about, let's say, composites, for many, many, many years, while filler particles changed, chemistry changed, at the end of the day, there wasn't enough change to warrant someone switching materials. In other words, if you were a Dentsply guy, you were using, Prime and Bond or Prime and Bond Elect and Dentsply composites. If you were a Kerr guy, you were using Kerr's Optibond and their harmonized material, or whatever it may be. In other words, there wasn't something to say, hey, I need to switch, because it looked good and it stuck. And all the materials look good and they stick. But most recently, manufacturers have started to create products that do more than look good and stick. Or they've reinvented their products to do more than look good and stick. And that area that you've heard probably the term probably used over and over again has been termed bioactivity. And for a product to really be bioactive, it has to have some meaning to you. It's got to do something. And a lot of companies, a lot of dentists, a lot of key opinion leaders kind of coined the term bioactivity depending on what product they're talking about. Well, I kind of did this way back when because I believed bioactivity was going to be this hot area. And for me, bioactivity, the definition for me is a bioactive product is a product that when placed in the tooth will desensitize, remineralize, strengthen, and have some exchange of ions with that particular tooth or the adjacent tooth. So it's kind of a catch-all term, but it kind of has to do a lot of things. And bioactive materials, while most recently have become this hot area, have really been around really for a long time. So if we go back into the 70s, we can call glass ionomers a bioactive material. Why? Well, it released fluoride, so it hardened tooth structure. It disinfected the tooth. And so it exerted some sort of a reaction. Did it prevent secondary decay? For the most part, not. But it did have bioactive properties. The 80s came along, And then the glass ionomers were enhanced with resin. And now you had RMGIs, resin modified glass ionomers, which the same bioactivity claims. Fluoride was released to harden tooth structure and prevent further decay and erosion, but it didn't really often prevent secondary decay. In 2009, well, the bioactive world took, I'll say, a twist, because way back when we had Dical to put under restorations to form tertiary dentin, but now we started getting calcium-releasing luting cements and different liners. And the calcium release was, in theory, to heal or regenerate tooth structure. It did that in some situations. Did it prevent secondary decay? The answer is no. In 2013, products were reinvented, and you saw bioactive resins hit the market. Resins that had calcium, phosphate, fluoride, that released potential tooth healing properties, ions, with the promise of stoppage of decay. Well, that really didn't happen either. So in 14, Shofu revisited their Giomer that had a 13-year history that released a whole bunch of ions through a pre-reactive glass core. Again, the question became is, okay, you have a composite that in theory has released these products, and there's 13-year history to show, but if you placed an adhesive, didn't it block the release of those materials? In 17, we saw Alkacide powder liquid restoratives come to market with an alkaline filler, releasing of hydroxide ions, and again, that didn't prevent secondary decay. In 19, just in the last 6 months, as a matter of fact, I was probably the first to show this clinically. Shofu launched their self-adhering Giomer. And basically what they did was they launched a product, I'll show you a picture in a little bit, called Fit SA, which was a self-adhering composite that released ions. So for those that questioned, will the adhesive block the ions? Here, the Giomer, this pre-reactive glass core that has ions inside, it released ions onto the tooth. It's too early to tell if it prevents secondary decay, but the theory is there. And now in 2020, we had a totally different launch where Vista Apex launched a bioglass bioactive material that had a unique chemistry with glass fillers that has been shown clinically, independently, to lead to hydroxyapatite formation, both in the medical and dental field. So this is exciting because so many people, when we termed the term bioactive, said, well, does it really do anything? Well, I told you at the Greater New York meeting last year, I did a live patient for Shofu and helped them launch Fit SA, a self-adhesive, flowable composite that has the Giomer technology inside. It was a nanohybrid aesthetic composite that polished well, that potentially could last long-term, that had a chameleon effect. And for those of you that have used a self-bonding composite in the past, well, Kerr had one years ago called Vertice, and it just fell out of teeth. It didn't bond to teeth. This chemistry is different from Shofu in that you get chemical and micromechanical retention into the enamel and dentin, yet the bond strengths are just okay. Nowhere near what you'd find with an adhesive, but still it saves the step of that adhesive. It's got the Giomer technology, which has 13-year studies on their restorative technology, meaning the fillings have looked good without secondary decay for 13 years. Whether it's due to the Giomer technology, I don't think anybody knows, but we're looking at studies. But you can eliminate the bonding layer using Fit SA. Here's just a quick clinical case that we did. Typical erosions that you'll see, and you see some decalcification here at these margins. We put an irregular bevel on this, no anesthetic. And that's just Fit SA, in there, polished. And I can tell you this was done 9 months ago, and it's not a year or 2 years, but 9-10 months ago. It's still there. So it looks good, it bonds well, and it's an interesting product. Does it have long-term bioactivity or any bioactivity? Studies are coming out. I can't tell you for sure, but theoretically it's possible. and it could be something worthwhile using in your arsenal. Vista Apex went in a different direction. They went ahead and they launched a product that has bioactive glass. Bioactive glass inhibits bacterial growth. It reduces microbial counts, and the alkaline nature of bioactive glass also contributes to a reduction of inflammation at the periodontal defect site. It has osteogenic properties, and it has the ability to form apatite. And these products go under the name of the Regen line. And Regen basically has an adhesive and a cleanser, let's say an etch and an adhesive, or a cleanser and an adhesive. And it has a flowable composite, and eventually there'll be a bulk-filled composite cement being launched into the line. Now, here's what makes this material different than every other. If you look at traditional adhesives, which work great, in theory, they've prevented bioactivity by creating an impervious barrier to the transmission of the ions into that dentin. And that was always the question with the Shofu products, and how was it getting past Beauty Bond if you're filling in tubules with adhesive? So that was always a question when it came to those types of materials. Well, here with the Regen line, what's happening is the adhesive is penetrating into that dentin, and it's creating this it's a bioactive adhesive, so to speak. So you're getting that penetration, and when you place the composite on there, they work synergistically together to form a true bioactive restorations. But if we look closely, and this is a study done by Burgess, and many of you know Burgess. It's an artificial caries model. And if you look here at the yellow box, it represents the area of the cross-section that they're going to measure. And the red circle is the portion of the dentin that either remained intact or eroded after exposure to the solutions. And here's what they found. What they found was that when using Regen universal adhesive and Regen flowable composite, the restoration was almost 250% more protective than a non-bioactive restoration. If you went ahead and used a non-bioactive adhesive with a Regen flowable composite, you got some protection. If you used Regen adhesive with a non-bioactive composite, you got some less protection. But when you use a non-bioactive adhesive and a non-bioactive composite, you got zilch. So this was interesting because it's really one of the first studies that kind of showed that by using true bioactive products, you're going to get less erosion of that tooth structure, which we know is our biggest issue when we have cariogenic bacteria, which are acidic in nature, exposed to the tooth structure in the mouth and from saliva. Interesting one done as well. So here is another example of the ability of Regen to buffer an acidic attack, because that's really the goal. The goal is our saliva gets acidic, and it's going to attack those teeth. Now watch what happens when you add an acid into the Regen area and how quickly it recovers back to that basic pH. So we add lactic acid, and the non-bioactive side has now become acidic, but Regen right away restores its color very, very quickly. That's a very powerful example, because when we have someone with high caries, we know their saliva is acidic and their saliva doesn't buffer very well. So you need protective mechanisms in the tooth structure that will resist that acidic saliva. So I found this to be very interesting as well. Let's take you through a clinical case. So this is one of my patients that just has high caries. The child, teenager, actually doesn't floss at all. And you'll see something interesting here. But my goal when I practice is I try to be minimally invasive. And I look at areas when things are decayed and say, all right, how can I preserve or conserve this tooth? Because studies do show if I bust open a box in every one of these things, even though I'm going to bond the tooth, I'm going to have a weaker tooth than if I didn't cut a box. Can I always avoid cutting a box? No, I have to sometimes. But look what happens here on this bicuspid, on this MOD. And I was able to get this great shot. This is what we tend to see. And I know all of you have seen this. On the proximal wall, you see a decalcification, but you do not see cavitation. Now, I can go through that decalcified area totally and create a tunnel prep, or I can cut a box in that area, or maybe I can put a bioactive adhesive to put an impervious barrier here, and then a bioactive restorative as our base to create, if you will, an impervious wall, and that material and adhesive will remineralize this area. Now, I know you're saying Kaminer is crazy, but at the end of the day, if I can avoid cutting that box and crippling this tooth, I had to cripple this tooth. But if I can avoid crippling this tooth, then I'm going to have a much longer lasting restoration. Plus, I'm also going to have a much better looking restoration. So this is an area that we look at all the time when we're cutting these boxes on these high caries kid. And it'll look like early incipient enamel decay, not into dentin. Some of you may watch that, but for me, watching is waiting for it to get into dentin, because it will at some point. My goal is to open it up in a minimally invasive way and try to remineralize it. So here I used Vista Apex as regen. And the first thing we did once we opened it up is we used the cleanser on the tooth. It's clear gel. We brush it onto the area. The cleanser actually removes contaminants from the tooth surface. It cleans and disinfects to ensure a pristine surface. It roughens the enamel and dentin to promote bonding, and it creates a much better adhesive environment for that adhesive and composite restoration. What's in that cleanser? Well, it's not phosphoric acid. There's nitric acid inside, and the nitric acid has a very, very low pH, under 1, and that's what you really need in order to etch teeth. It has some alcohol inside, which will allow the regen to disinfect the surface before bonding, and it has some HEMA, so it'll act as a desensitizer. Again, bioactivity, not just in the adhesive and the restoration, but also in the cleanser, and that it has some HEMA to desensitize. So we put that on, we rinse it off. We now liberally apply the Regen Universal Adhesive. Now, it's really, really important, and I say this in all my programs, it's really important to read instructions. Because if you read the instructions on Regen, it'll say you want to apply it, 20 seconds, let it sit, dry it, and then apply another layer. So think about that first layer seeping into that dentin. That's what it's actually doing. And then you're going to light cure this. Notice a different curing light here. And this is another Vista Apex product. It's called the Pink Wave. You see the red curing light. And this red curing light uses what they call quad wave technology. So 4 different wavelengths to enhance the curing of your composite. So very interesting. It's red as opposed to blue. It's not a hot light by any stretch, and it's a great addition to an arsenal. So we've cured. You see I've restored this one. I'll tell you what I restored it with in a second. We've cured, placed our adhesive here, and we'll take you step by step. We've light cured our adhesive, and now I've placed a layer of the Regen flowable composite. I placed that along on the floor. I'm going to light cure that. Now I got to backfill it with something, and I still want to stay along the lines of the bioactivity kind of space. And now I have options. I could go with Shofu's Beautifil because it has Giomer technology. The handling is a little finicky for some. In this case, I chose to use a composite from Voco called Admira Fusion Extra, and I'll tell you why in a second. So we've backfilled that with Admira Fusion Extra. Very interesting material. It's a single shade bulk or incremental fill, so you don't need a whole bunch of shades. It's BPA free with extremely low shrink, and it's also extremely aesthetic. So BPA free kind of still fits the bill of being within the bioactive kind of territory. I backfill that. I polish that with, in my opinion, some of the best polishers in the industry. I don't often say that, but these are the ASAP polishers from Clinician's Choice, and they just really get things really, really shiny. The purple is a pre-polisher, the pink is a polisher, and when you're done, the restorations look super shiny, as I'll show you. There are two types of diamond particles, or two sized diamond particles in these polishers. And you can buy this from Henry Schein. You can buy it if you're from Canada. You can buy it from Clinician Research. There's a 44 micron diamond in the purple pre-polisher, and there are 3 to 6 micron diamonds in the final polishers. And you can autoclave these up to 30 times. And when you're done, the restorations just disappear into the tooth. Now think about what I did here. I have the bioactive adhesive underneath. I then have a bioactive flowable in both from my base of my restoration. And then I've put a BPA-free composite from Voco, Admira Fusion Extra, and cured that and polished that. So it kind of has multiple layers of protection within these restorations. And what happens is, and this is what's incredible about this particular product, Admira Fusion Extra, is that it's a single shade composite, but their chameleon effect is such that it just disappears into the restoration. And let's take you through one more. And here's an example of what I'm talking about. You have these early lesions. It's not into dentin. It's not into dentin. But when you open these up, these are cavities. So I've opened these up. I've done tunnel preps. This was an OL. This is just stain. I actually tested that with a caries detection device. I've opened this up. Again, you could barely see it here, but right here you could see that same decalcification that I was talking about. This is what we see, and I think it's almost criminal to cut that box. I mean, let's say it doesn't remineralize in 4 or 5 years, but just stops there. Okay, your x-ray will look a little bit different. You got to know that, but you can always go back and cut a box. In the meantime, you've preserved and conserved tooth structure. Here's another good image of that, and you can see the decalcification. So again, we go through the same process. We place our cleanser, our Regen adhesive. This is our Regen Flow. Right in, light cure that. We place Admira Fusion Extra on top. Notice, different color tooth, totally blends. We polish that, then do the molar, same thing. And again, once again, you have this bioactive type restoration with materials that just blend into the tooth structure. So I think this is an interesting addition in the restorative side where we've gotten to, and it's really worth looking into. Especially, and this is what I tell my attendees when we go to a lecture. Let's say you say to me, Eran, I get it, but it's not for me. Okay, but I'm going to go back and tell you, great. Use these products on your high caries patients. Use the adhesive and use the flow on your high caries patients. We all have those. On your geriatrics. So think about people who have high caries and almost customize your materials. So you're using a bioactive composite on these high caries types patients, and then you're following it up with another bioactive type bulk fill, if you will, anterior, posterior composite, like Voco's Admira Fusion. So at least think differently. And you'll see my last slide in the program, which will reinforce this. So let's jump over to more chemistry. So we talked chemistry for direct restorative dentistry. Now let's talk chemistry as it relates to endodontics, because endodontics today is a lot about chemistry. What we're going to irrigate with, how we're going to get that irrigance to the apical third, how can we open up these canals in a minimally invasive way? Is there a proper protocol where we're opening the canals wide enough or not wide enough to get irrigance to that base? And let's talk about how we can improve and be more efficient with our endodontics. So I think no matter where you go, no matter what textbook you look at, there's no question that the concept of assisting your preparation of the root canal has to be followed up with a precise, rigorous, intense disinfection protocol using appropriate irrigants and intracanal medicaments. And I think that's pretty much undisputed. It's been around for many, many, many years. And there's manufacturers today that are actually coming out with a variety of different types of products to propagate those disinfectants in the canal. There is a program or a protocol using a hard tissue laser that I taught many years ago. Let's say using the water laser, the Photona hard tissue laser. There's a protocol called PIPS, photoacoustic induced streaming of irrigants that will propagate liquids in a controlled force down the root canal system to get into the lateral canals. So there's no question the concept of irrigation has really been around for a long, long time. And that concept of irrigation involves hypochlorite, EDTA, chlorhexidine, and then some sterile water. That's kind of been the protocol for years. But listen, endo is just, and I joke with my endodontist, who's my closest friend, is the most imperfect science we have. Because the complex root canal anatomy of teeth, of most teeth, make it hard to access every part of the system. That's why we see beautiful endos fail 10% of the time. And that's a true statistics, because you have all these outcroppings and outshootings within the canal system. And if you just look at these roots, how are you going to go ahead and get irrigants down these canals just with a needle and a syringe? It's just very hard to happen. You're likely not going to get a file into all these areas. This is why endodontic statistics, true statistics, are as follows: 90% success rate overall, non-vital, vital, overall 90% success rate, but retreats fall to in the high 70s. Now here's where you have to make some decisions. Let's say you see a good endo. Endo was done well. Upper molar, mesiolingual canal, mesiobuccal, distal palatal, all filled, and you have a failure. Now, the studies will tell you have a 75% chance or 77% chance of a retreat working out. Now, is it incumbent upon us to inform our patients, well, listen, you're going to go ahead and retreat this. You just need to know from the get-go, you only have about a 75% chance of success. And if you extracted it and put an implant, you may have a much higher success than that. And I think it's important to present that to our patients so they can make a decision. Because you know what happens if that endo fails a second time, whether you did it or not, whether the specialist did it or you did it, they're going to blame you. They're going to blame me. Well, you sent me to that specialist. You told me to do it. So we know that success rates are what they are, but we can try to maximize these success rates by just adopting a certain protocol and adhering to certain rules. Let's look at some science so you don't just say Cameron is just snowing you. A study from 2012. And the purpose of the study was to discover current trends in irrigation amongst endodontists. And what they found was that most of the respondents are using full-strength hypochlorite and are routinely removing the smear layer during endodontic treatment. In addition, almost half of the respondents are using an adjunct such as ultrasonic activation to aid in their irrigation. This is 2012. In 2020, I'm going to tell you about 75% of endodontists are using ultrasonics to activate, yet GPs, the number still remains very low. 2015 study, comparing the evaluation of the effect of different irrigation solutions against E. faecalis, which is the bug of bugs when we talk about endo. So the results showed that group number 3, which was 5% hypochlorite, followed by 17% EDTA, and followed by 2% chlorhexidine, showed maximum antimicrobial activity in all the 3 different time intervals. So using this tripartite of irrigants gave you the best results. Now notice in this study, they didn't say Clorox. I know you're all laughing because Clorox is not hypochlorite, it's bleach. It is, but it isn't. And the reason it isn't is because if you irrigate that tooth and you by chance make a mistake and get some irrigant past the apex and end up in a lawsuit, and the attorney says, doctor, what strength hypochlorite did you use on your patient? And you go, Clorox? You're not going to be in a good situation. So here's what I would tell you, ladies and gentlemen, don't be cheap. Use hypochlorite. There's a number of companies that sell it. Vista Apex does. There's a number of companies that do, variety of companies. Ultradent, Vista Apex, many people do. Find one that you're comfortable with and use it, but don't use Clorox. This is Vista Apex's Chlor Extra. It's a 6% hypochlorite, which is enhanced with proprietary surface modifiers and wetting agents. So because there's surfactants inside, it improves the depth of penetration, and it's 2 times faster dissolution of tissue than standard hypochlorite. The surfactants also make things, make files glide more smoothly in the canal. So you have this lubrication in the canal using this product. Again, don't be cheap here and use Clorox. Use a dental certified product. Once we've instrumented our root canal system, gotten everything out, however way you're doing it, we're not going to go into that today, and you've irrigated with hypochlorite. And what's hypochlorite going to do? It's going to remove tissue. It dissolves tissue. That's the purpose of hypochlorite. Besides disinfecting the canal, it removes tissue. So the tripartite, the back end of the irrigation protocol, next would be to irrigate with EDTA. And I'm going to try to say it, but it's ethyl ditriaminic acid and chlorhexidine. So the EDTA opens up the tubules, and the chlorhexidine acts as a bactericidal in the root canal system. And studies do show that chlorhexidine, the bactericidal activity of chlorhexidine, can last in those tubules upwards of 2 weeks. So for those that have not used chlorhexidine and EDTA and chlorhexidine in that order, you should. Now, the problem is you have to use it in that order, because if you use chlorhexidine first, then EDTA, for those that have made that mistake, you'll get this kind of bubbling effect in the canal. We don't really want that. So Vista Apex has made life easier. And what they've done is they've created a chemistry called Smear Off that is EDTA and chlorhexidine in one cleanser. So you do not have, so you can still do the tripartite of cleansers, which is hypochlorite, EDTA, chlorhexidine, but you only need the chlorhexidine and the Smear Off to get it done. If you don't want to use the Smear Off, you can do EDTA and chlorhexidine. That's fine, but they've made life easy. Now, many of us, GPs especially, for years and still now, continue to irrigate the root canal system with a syringe. Some even don't use any of these irrigants. They use local anesthesia. I've heard that. But there's plenty of research to show that conventional manual irrigation may promote less root canal cleaning, especially in the apical third. So this study done by Tanamaru and Philo was compared the cleaning of the main and lateral canals using a number of different irrigation methods: negative pressure irrigation, endovac, passive ultrasonic, and manual irrigation. And what they found was conventional manual irrigation techniques may promote less root canal cleaning in the apical third. For this reason, the search for other irrigation protocols is important, and endovac and passive ultrasonic irrigation are good alternatives to contribute to irrigation effectiveness. Another study. Now here's what's even more important. These were investigations into E. faecalis biofilm removal by passive and active sodium hypochlorite irrigation delivered into the lateral canal with singulated root canal. So what is done here is it's taken kind of the bacteria we want to kill in the most difficult situation and compared it using manual or passive irrigation versus ultrasonic or active irrigation. Here's what they found. The greatest level of biofilm removal was obtained with ultrasonic agitation, followed by sonic, which was next, and manual agitation, which was next, and passive, which was last. The differences were significant between the residual biofilm in the passive irrigation and both the sonic and ultrasonic groups. So obviously from this study, ultrasonic was substantially higher, almost 20% higher in removal of biofilm than the Sonic. The Sonic was only a couple of percent higher than manual, and the passive irrigation group, with just squirting some liquid in there, was obviously the lowest. Enter, make my life easy, the Endo Ultra from Vista Apex. This is a handheld, rechargeable, ultrasonic unit with a bendable tip that will allow you to, by pressing a button, agitate liquids down the canal in an ultrasonic fashion to get that liquid to propagate into a variety of lateral canals and down the apical third. So by using the Endo Ultra, you're getting this propagation of irrigants into all these lateral canals. You're going to break up biofilm in these lateral canals. You're going to lower bacterial levels, as shown in that last study. And because it's handheld and not another plug, it can easily sit on your countertop, and you can incorporate that tomorrow into your Endo protocol. And by the way, it's very, very inexpensive. So it's cordless, it's compact, it's battery operated, it's simple to use. It produces the acoustic streaming that we're actually looking for and the cavitation that we're looking for that will allow us to get into the lateral canals. I actually, when using this, when you turn it on, you don't hear brrr, like you think it's going to do a lot. But when you put it in the liquid, and I tested it first just in a little Dixie cup with water, a plastic cup with water, you see how quickly this propagates. It's 200 times more powerful than Sonic. So in the study, you had 20% increase from the ultrasonic to the Sonics. Here, this is 200 times more powerful than Sonic competitors. It's cordless, and the tips are single use. So you can kind of, the tips can be autoclaved up to 50 times. They're not single use. They can be autoclaved up to 50 times, which we always worried about fragility with these tips, but 50 times you can use them. So you can feel comfortable that when you place this in the canal, that you're going to have proper agitation even 35, 40 times later. Now, interestingly enough, even though the tip is long, you don't have to get it down to the apical third. If you place this tip, you can do your own experiment, and I've done this. Place the tip just in the coronal third, and you'll see the agitation. I try to get it at least halfway down, but what you want to avoid is any constriction in the canal. So if you have any constriction in the canal, do not force it. Just set it above that, and this will agitate the liquid down past that constriction into all these other orifices. The crazy thing is if you do it and hold your mirror, so what we do is we have our rubber dam on, we hold it, we use a mirror, and I can actually see, so I'll place some liquid in the canal and I can actually see it agitating that liquid right down the canal and seeing the debris actually come out. Okay. So this is a study done by Vandersloot with devices like the Endo Ultra. And watch what happens here when you talk about sonic versus ultrasonic. So we're going to go ahead and put this tip in the canal, and with a sonic tip, you're not going to get the disruption that you will with an ultrasonic. And now you're going to put something like the Endo Ultra in the canal, and look at the difference in the effect in that particular liquid. It's literally like a tidal wave forming in the tube. So for those that are using Sonics, I can tell you you're not getting enough propagation. This alone tells you that you should be able to clean better. And if, a lot of people will come to me when I give endo programs and they say, give me a simple tip that I can use to improve my endodontics. And I will tell you, just use ultrasonics in your endo, and right away you're doing better than most. And what you're going to find is by using the ultrasonics, what you're going to find is when you go to fill these teeth, you're going to fill these, and you're going to get into lateral canals like you've never gotten into before. And that's kind of shows you that this technology is really working for you. If you look at Vandersloot's study, he found that ultrasonics are almost 90% effective in the cleaning of the canals, getting them free of detonal debris, compared to the Sonic group, which is basically 5.5 to 6.7%. So again, when you start looking at chemistry and you start looking at propagation of liquid, it would make sense to you. And let's be honest with ourselves. We've all done endos that haven't worked out, and you say to yourself, I don't get it. I followed all the protocols. I'm using the proper irrigation protocols. Why did my endo fail? Well, the simple reason is there were lateral canals or lateral propagations, if you will, that you could not get to with the technique that you were actually using. So I think that it makes a good case here to say, maybe I need to incorporate ultrasonics into my endodontic protocol. It's interesting that as we're getting near the end, I'm going to leave about 10 minutes for questions and answers, because I expect to have a number of questions. So you could type your questions in the chat, and in the question and answer, I will make sure to answer everybody at the end. But it's interesting when we start to focus on chemistry, something that I can tell you honestly, day to day, most people, maybe even myself, are not thinking about. And more so now on the restorative side, and definitely on the endo side, because I've taught endo for years and we do a lot of endo in the office, but definitely lately on the restorative side, I'm looking at teeth like I showed you that have decalcifications in the proximal wall, and I'm saying to myself, hey, how do we go ahead and do this? How do I go ahead and save that tooth? Here's another example of sonic versus ultrasonic irrigation. This is the endo activator. You see that second channel, if you will, call that a lateral canal, and putting the endo activator in, we're not getting enough propagation of anything into that lateral canal. Here, the endo ultra, look what starts to happen. The liquid is forced up into that lateral canal. So I could show you a ton of animations like this, and you will be hard pressed not to say that, okay, the propagation, the ultrasonically driven liquids have to improve my endodontics. And I'm working on a number of things that I don't want to talk about yet, but you can almost conceptualize that if you are able to clean these types of canals, then taking a gutta percha point and wiping it in sealer and putting it in the canal may not be good enough. Maybe you want to think of injecting your sealer into that canal, maybe under slight pressure, to see if you can squirt sealer into these lateral canals that you've now cleaned free of debris. Because keep in mind, at the under end of this lateral canal is an exit portal. That's where your infection is going to start if you've not gotten liquid, or if you've not gotten sealer into those areas. So in your mind's eye, always remember that we are looking at things through x-rays, through our eyes in a two-dimensional fashion, but we work in a three-dimensional world. So realize when you're irrigating, when you're cleaning and shaping, when you're irrigating and doing what you're doing, you have to think of things that you're doing them in three dimensions. And I guess the rule of thumb with endo is like this. When you think you've done irrigating, start irrigating again. So the rule of thumb is irrigate, irrigate, irrigate. And when you're done irrigating, irrigate, irrigate, irrigate. You can't irrigate enough. Most endodontists will tell you that the cleaning and shaping is critical, but if you clean and shape well and you do not copiously irrigate, if you looked at my slide of irrigation, the first slide was a waterfall. If you don't copiously irrigate, you still have a decent chance of falling into that 10% of failure in the root canal system. So the goal tonight was to get you all thinking of chemistry. What type of restorative material and adhesive am I putting into my tooth? What will that adhesive and restorative do to the dentin, to the enamel, to recurrent decay in and around that tooth? What will that material do to solve problems of sensitivity. Because if you're just putting the same composite that you've used for the last 10 years into that tooth, what you're not getting is the bioactive type advantage that you could and should be getting with the newer materials like Regen and the other materials that are out there. So the goal, I think, whether we're talking restorative of endo, is to be more successful. And if we consider some slight changes in our protocol, adding certain things into what we do, both on the restorative side as well as the endo side, I'm confident that we can be more successful. So I think the bottom line is that while we don't often think about it, I think I've showed you tonight that chemistry does play an important role in many aspects of our day-to-day dentistry. It really does make a difference what we're doing and what we're putting in. And I'll leave you with a quote, and then I'll get to the question and answer. I see there's some questions already. And this is kind of the essence of what I tried to do tonight and in my programs. And I readapted a quote from a book written by a surgeon from Mass General. His name is Atul Gawande. And it goes like this: look for the opportunity to change. I'm not saying you should embrace every new trend that comes along, but be willing to seek out the inadequacies in what you do and seek out solutions. As successful as dental medicine is, it remains replete with uncertainties and failures. That is what makes it human and also so worthwhile. The choices we make are necessarily imperfect, but they can alter patient lives. And because of that reality, it often seems safest to do what everybody else is doing, to be just another white-coated cog in the machine. But a doctor, hygienist, must not let that happen, nor should anyone else who takes on risk and responsibility in our society. So find something new to try, something to change. Just imagine in my class too, if I just don't do what I'm doing and I just bust open a box on every one of these, I'd be doing exactly what everybody else is doing. And that's never, ever been my MO. I want to gain an understanding of the materials. I want to do no harm, but I want to be that person that says, hey, I was able to conserve and preserve this tooth by just using some new materials that can make a difference. So listen, with that, I want to thank you for joining me on my 35th league leading webinar. And I'm going to get to the question and answer since there are a bunch of them, I think. So can I ask me, do you total etch when using Regen? Well, the cleanser, if you will, is an etch. So the answer is yes. I'm going to total etch with the cleanser before I use Regen. And don't forget, besides having the acid inside, the nitric acid inside, it also has HEMA, so it's going to assist in desensitization. Can Endo Ultra be used for calcified canals? You can use it in any canal. It's not going to open up a calcified canal unless you have tissue blocking it, which it could assist in doing that. But you also want to make sure not to place that tip down too far into that calcified canal. So you don't want any resistance. You don't want that tip to break. What type of gutta percha do I suggest? I always try to use the gutta percha that is matched in size to the instruments that I'm using. I also kind of like to keep things in the family. So if I'm using Brasso's files, I'll use Brasso's gutta percha. Ultradent used to have files, used to use their gutta percha. Whoever it may be, Metadenta files, Metadenta gutta percha. Whoever's files you use, I like to match the gutta percha right up to it. Any concerns with pacemakers and the use of Endo Ultra? It's a great question. I don't believe so, but and again, I've never seen a reaction with any ultrasonic device with pacemaker, but I would still take the same precautions you would take with any ultrasonics with a pacemaker. I do use my ultrasonics with pacemakers, and I've never had a problem. I'm not telling you to do that. I would just take the same precautions that you normally do with with traditional ultrasonics. How long do you ultrasonic a typical canal? Also, is there just one tip size? So I typically will ultrasonic a canal for about 1 minute with each cleanser. So I'm going to use copious irrigation. And I'm going to go ahead and put my file down there and see if things are smooth. I'm going to go ahead and do that and place them down into the canal system. And you can look at the Vista site, and it'll talk about the tips themselves. Will the ultrasonic increase risk of extrusion of sodium hypochlorite past the apical opening? The answer is, well, if you have a blunderbuss apex, or if you opened up the apex, what I would likely do, since you have to irrigate anyway, is I would place the ultrasonic only at the canal orifice, not go any further than that. And again, I'd be very careful, but you have just as much risk if you're taking a syringe and squirting it down there, if you're putting any kind of pressure, unless you're getting that syringe the same way, only at the orifice of that canal. I think any sonic increases your risk of any liquid. So if you don't feel comfortable with hypochlorite, then I would just go ahead and use EDTA and chlorhexidine or smear off with the Enda Ultra and get that down into the root canal system. So a lot of great questions. Any other questions as we're running out of time, as I pass the baton over to the people from Viva Learning? So I think that's what we got. I want to thank the 500 of you that attended tonight, and I look forward to spending time with you on another webinar in the future. Thank you again.